if you don't know how to, if you operate on patients that are the difficult patients, then you'll have trouble with them afterwards. So, assessment for rhinoplasty. Those of you who are interested to actually read it, it's in the journal, one of the previous journals, 2013, that's actually available online. You can have a look at the chapter. This is basically what I'm talking about here. Some additional one was published just very recently in the, I don't know why it didn't show, in Scott Brown. Ooh, it's jumping, sorry. Yeah, here you are. Just been published in the Scott Brown, which is a bit expanded, again, about assessment for rhinoplasty. So, I don't know what's happening. It's jumping the slides. Let's try it again. Something funny in the computer. This one. Here we are. We're in business. So I always talk about 3 analyses. Why? Because the first one is the most important. Second one is very important. The third one is really important as well. But the first one is the one that will actually help you to assess the patient himself or herself. You want to assess the patient because you want to select the patient appropriately, and then you can look at the face and then the nose itself after that. So assessing the patient, you need to actually know, is the patient good enough to have surgery, ideal patient, or a patient who's not going to be happy with anything you do. So this graph was created many years ago by Gorney. The red part is the bad one, and the green one is a good one. These patients have high concerns, like the level of concern is up here, but the deformity is tiny. So the patient who are too concerned about the noses are not the ideal ones. The patients who have severe deformity are concerned appropriately about it. These are the realistic patients, realistic expectations, and the good patient you want. So we'll talk about all these in a minute. There's lots of data on the poor results are due to emotional dissatisfaction, not the technical failure. So I have a good result, but the patient is still unhappy because they expected something different. So that's the balance you want to reach. You want to have a patient who actually expects something that you can give to them. It's very nice to have something like this when we talk to the patient in the clinic. I actually show them this. I draw it. I'll show them a graph. I'll tell them, you can change the nose, but not completely give you a new nose. For example, if a bad nose is 1 and the best is 5 and yours is 2 or 3, you can jump 1 step in the majority of cases. If we're really lucky with the tissue allowance, maybe you could jump 2, but it's impossible to jump 3 steps. So that's a simplified way of giving the patient an idea about what to expect. I like this one. I keep putting it in my lectures because it talks about the ideal patient. It's been described many years ago. Ideal patient is SYLVIA, secure, young, listens, verbal, intelligent, attractive. And you think about it, usually, typical patient like this, a young lady most of the time, that's a reality. She knows what she wants. She's just concerned about the tip, about deviation, all this. You give her the nose, she's very happy. Even if it's slight asymmetries, they're usually very happy. In my experience, SYLVIA is a good patient. But Simon is not a good one. Sorry, Simon, but he's not here today. So Simon, single mature male are expected narcissistic. It doesn't mean that just males are difficult rhinoplasty patients. It's just some. These are the usually young males who really obsessed with the noses. And you actually think, you feel a gut feeling there's something not right. The ideal example of this is obviously Michael Jackson. I keep putting it, and I've not been sued. I've done this for about 15 years. I've been talking about him, but nobody sued me. I think I'm not the only one anyway. But he is a Simon. He wanted operations again and again. He was never happy. He had body dysmorphia, basically. We're going to talk about it in a minute. So he keeps having surgeries. You want to avoid these patients. Examples of this is exactly that patient who came to me years ago. I like putting this one because he was 18. He wanted to pay the operation immediately. This is what he said. But for the most next week, and I want to look like Ronaldo. So if you do this, I think you make a mistake because obviously the patient has something in his mind that is not realistic. He wants to look like this footballer because he liked him at that time. That was years ago. He's very young. He's obsessed with his nose. There's some event that is happening in a few weeks' time that he wants his nose to be done before that. So you don't do this nose. You have to actually avoid this, even if you're not sure what's happening here, what's the psychological problem behind it. Another example, unusual patient who wants somebody else's nose, but that somebody else is completely different. So you have to actually realize there's something not right here. So you don't operate with this patient. Patient will give you lots of diagrams. Again, this patient sent me lots of letters. One of them was this, with this picture here, Ava Gardner in the movie Flying Dutchman. I want the nose to be like this. obviously you tell them this is not realistic, and you don't do it. Nowadays, patients study the internet and study the anatomy and draw diagrams to tell you how to do the operation. So this is obsession, right? Obsessive personality, and they're probably not going to be happy. So I suggest you don't do the operation with these patients. You make a mistake and you do an operation, and patients come with diagrams like this. This is a problem. That was one of my early patients. I missed the body dysmorphia, and that just a week after the surgery, the patient came with these diagrams. You could see, you could tell something is not right with this writing going sideways, and this is a bit tilted a bit more, this is straight, and all this stuff. And you can't read it properly, but it says here that the people walk in my forehead. So there was something completely not right about the patient, and it's a mistake. The patient will never be happy, even if the result is good. This is a very recent one, only a few weeks ago. So a letter was sent to me. The patient has a swollen nose. In the past, she thought she was Nefertiti, the Queen of Egypt, which has the most symmetric face. I'll show you later. Did I operate? Definitely not. Here she is. So here's the diagnosis of a patient who wrote me all these things and said she has people in her forehead after I sent to psychiatry. Unfortunately, after the surgery. That was a mistake when I was very young. 17 years ago, I was beginning in my job. So she had body dysmorphic disorder, delusion disorder, alcohol dependence, and depressive episodes. So should not operate on that patient. And she kept coming, wanted more surgery. It's very hard, referred it to colleagues. Still doing the same, kept going. This kept going for a long time. And she really needed a psychiatric treatment. So body dysmorphic disorder is a very important thing. It's described by psychiatrists from Modena, Morselli. It's a subjective feeling of ugliness or physical defect, which the patient feels. So they feel it, and they feel everybody could see it, but in reality, they look fine. Okay? And it's commoner than you think. This is a doctor I met last year in Rome, and he came to me. I was lecturing, giving this lecture. He said, I am Morselli. His grandfather did that thing. He discovered described body dysmorphia, and he's a plastic surgeon. I said, why are you doing this? You know about all these difficult patients. He said, yeah, well, this is my interest, and I wrote a book about it, and I work with a psychologist. So this man understands this condition, so he can avoid these patients. It's coming to the media. This is a couple of years ago. There's a long series about this, and this patient here thinks she's very ugly. She can't get out. She keeps taking selfies, 300 selfies a day, and deletes them because she's looking and she just gets upset. So it's a serious psychological condition, and you will see them if you do in cosmetic surgery. There's a psychiatrist who specializes in this. He's the one I refer my patients to, David Veal. He wrote so many books. He made so many videos. He's a psychiatrist, so he creates a funny thing in his website. But he's an expert in body dysmorphia, and you'll see it. You almost see 20% of your patients coming to you with this condition. So this comes to take us to the high-risk patients. Obviously, the highest risk is the body dysmorphia because they will never, ever be happy. Then patients who just demand too much, they're always going to keep demanding. They're not really ideal patient for you. You want somebody that you feel comfortable with. A patient who insists on secrecy. This is an interesting thing. The patient who insists on secrecy, they're a problem because they have no family support, friend support, and so on. Having rhinoplasty is a major operation. And if there's any complication and so on, they get upset. And I have experience with a patient like this who was very unhappy, insisted not to tell anybody, but I thought she told her family because I asked her, but she didn't. And then she came back crying. Only about 3 weeks later, I made a mistake. I should not have had this operation. So that's one thing that you should avoid. Make sure the family are there to support the patient. The surgeaholics are these typical patients have come to you. They've had 5, 6 operations, 4, 5, 6, and the nose is not too bad, and do one more. I would not think don't operate on these patients because usually they're body dysmorphic. Obsessive patient, like I showed you, the patient with obsession will draw things and give you all these diagrams. They think they can perfect the nose and all these things. They'll never be happy when there's slight asymmetries and so on because you can't always make the nose perfect. In reality, you can't. There's never a perfect nose anyway. And this has come to this as well. I'm a perfectionist. I have patients who come and say, I'm a perfectionist. I want this to be like this. So then I tell them, essentially, the nose is tissues, human tissues. There's 4 types of tissue in there that interact: cartilage, skin, bone, and mucosa. And you can never make it follow you like a piece of plasticine or something. You have to explain that to them. If you feel they still think that you could do that, you don't operate. We don't like the impolite patient who are usually horrible to staff, but they come to you, they're very nice, but the staff come and tell you they're really horrible to me. They will be horrible to you if they're not happy with the nose, so maybe you just have to be careful with them. And interestingly, the other part of the spectrum, the flattering patient who come and say, you're the only person in the world that will go for to have my nose done. And obviously they think too much of you and they expect too much, and you have to really explain to them and bring them down to earth and make it realistic. Okay, so be careful with a flattering patient, too flattering. If you're not sure about any patient, reschedule, see them again, ask a colleague, and if you think there's a psychological psychiatric condition, send them to a psychologist, psychiatrist who understands the body dysmorphia and so on. So not any psychologist. Like I showed you, I work with David Veal, but there's another psychologist in the Royal Free who will send her patients, but now we have advertised, I have money to appoint a psychologist just to work with me. See how important this condition is. So we are the first hospital in England, I think. So we have a psychologist. We'll advertise a job next week to work with us to exclude patients with body dysmorphia and other conditions. Just to show you a couple of things, can we diagnose it? There's no way of diagnosing these things. There's no way really for us to avoid them completely, but there are some questionnaires. We did a study a couple of years ago in the Royal National in Charing Cross. We looked at about 100 patients coming for rhinoplasty. We gave them this questionnaire. It's a generic questionnaire for the whole body, for body dysmorphia. We gave it to them, and we gave it to a control group. When we looked at the results, we found that 32% of the patients who came for receptor rhinoplasty in the NHS, not private even, were positive for the questionnaire. So they all went to see the psychologist. Psychologist did a proper examination, assessment, and all that. So they found that 20% really have body dysmorphia and should not have surgery. So that's huge, isn't it? 1 in 5. Interesting, 4% of general population who just came for ear surgery and things had body dysmorphia in that questionnaire. It means it's slightly maybe not sensitive, or maybe it's a bit over-diagnostic, but it's still. There are some questionnaires created for the nose, like this one from Utrecht, which is quite good. 5 questions, you give it to the patient. It can give you an idea about who is the difficult patient. The author of the book here, Peter Lohaus, is the one who did it. There's another one which is a bit better, was published more recently. It's got 7 questions by Peter Hellings, a group from Belgium. Has a couple more questions to exclude. The problem is, though, patients learn these questions and they learn how to answer them, but still, they are useful, a screening tool. You can, if you suspect your gut, your clinical assessment, process the questions, then you think, explain to the patient you're not comfortable, and very nicely explain to them, I think there's some other things, and I do work with the psychologist a lot, and if you don't mind, see them, just assess, and then if everything is fine, we're happy, we'll go ahead. But I have to go through this step first, and they're usually fine with that. Good. Okay, so see how long I talked about this, because it's very important. Now we'll talk about the things. The face, just have to have an idea about facial aesthetics and symmetries because of a couple of things. So here's my patient who thinks she's Nefertiti, the other one. Nefertiti's statue created to be very symmetric, which is not real. Everything is symmetric there. Nobody's completely symmetric like this. Majority of people have slight asymmetries, but some people have severe asymmetries. Leonardo da Vinci created the other symmetric thing, which is dividing the face into fifths and thirds. I'll show you in a minute, this one here. So he thought about this, like good faces should have thirds and fifths, which is true, with slight variation. So if you actually measure from the hairline to the nasion, to the nasolabial angle, to the chin here, it should be about thirds. And if you side, or like this vertical ones, ear, lateral, medial canthus, and so on, is fifth, with slight variations. This is a symmetric face. Most people run around this with slight differences. But some people have severe asymmetries, like this chap. Severe asymmetry is a problem because you can't tell if the nose is straight or not. There's lots of variation here. So if you look at this patient here, see the nose, is it deviated? Seem to be, but if you look, the ala here is much bigger than this. Maybe there's a slight deviation here, but his face is very asymmetric. It's bigger on the right than the left. If you look at this face, I created this many, many years ago, and I like it. I divide the face into 2, then mirror image them. So this right side, and make it, I mirror it to make it left, and this one I make it right. I put them together, get 2 people. This just tells you the patient is completely asymmetric. You have to explain these things to the patients, because so many times before I realize these things, after I do a rhinoplasty and asymmetric patient, the patients come back and say, my eye look a bit funny since you did that operation, because you start noticing these things. You start looking at their face. My nose is still twisted because you can never make it straight in the relation to the face. So you just have to be aware of this and tell the patient, explain it to them, especially with twisted noses. So, yeah, so it can give you illusion of a twisted nose, and if severe rhinoplasty can make it more noticeable. So that's why you have to look at it. Now let's look at the nose. So analysis of the nose, 7 things I look at, which I'll show in a minute. But if you think about any part of the body you examine, anything, you got to do inspection first, and you got to palpate, which I do with the nose. But then you're going to do photo review and then planning. This is my quick assessment in the clinic. When I see patients coming for rhinoplasty, I look for it, inspect, and I really do palpate the nose, and then take the photos there and plan it. So let's think about this picture. 7 things, as I said: skin, deviations of the nose, the length of the nose, the projection of a tip, the dorsum itself, what it's like, the tip, and then the alar base. So skin. What's the importance of the skin? There's so many different types of skin, but the extremes are the thick skin and thin skin. Thick skin, like this patient, is very sebaceous. You cannot make the nose very tiny. Some patient will come to you like this and say, I want a really small nose and all this. You can't, okay? Because it will not allow you. But if it causes an irregularity, creates some irregularity underneath, it's not going to show, so that's an advantage. Thin skin like this lady, it will show any minor irregularity. She has not had a rhinoplasty yet, actually, but you can see the contour of the nasal bone here. So that's another thing. So if you rate any irregularity, it will be a problem, but you can create the shape that you want. So you have to be aware of this and explain to the patient. Deviations, we'll see this a lot, all the time, obviously traumatic noses and so on in the NHS, and it's one of the hardest noses to correct. In a nice way of actually analyzing them and dividing them is to think about thirds like this. So upper third is the nasal bones, middle third is the bones, and upper lateral is the septum, and lower third is the rest of the septum and the lower lateral. Why? Because you can plan your surgery on that basis. So this is what I do when I look at the patient. I divide them into thirds, and I'll say the upper, middle, lower thirds all go into the left, for example, like this, or the upper and the middle go into the right, and this one is central. And then you think about it that way. Your middle third is the hardest one, so your middle third twisting like this and irregularities is difficult. You have to think about it, and when you look at it, when you separate it and isolate it from the other, you realize you have to do something about this, and mostly open approach to actually correct it properly. The length of the nose is important because nowadays, I see a patient coming for cosmetic surgery privately. My nose is too long, doctor, a lot. Yeah, they think it's too long. And sometimes it doesn't look too long. You have to be aware how to actually measure it, which is very simple most of the time. And the simplest way is that the nose from the root here, from the radix to the tip, is equal to the distance from stomium to mentum, roughly, really, okay? So you don't have to have a rule to do this. You can just put your hands, but you can measure it for the patient. So that's one way. There's so many other measurements. One is a bit more accurate is from the tip to the stomium here, 1.6. That's the other way. But there's lots of other ways. But if you want to be quick in a clinic to show the patient, you could do that one. Then there's projection of a tip, which is very important. Again, a lot of the patient will come and say, my tip is too long, doctor. Obviously, this is too long, yeah? But tip projection is the distance from the tip here to the alar groove divided by the distance from the tip to the nasal, which is very easy to measure as well if you have to. Though most of the time you can tell. But measuring it for this chap, 0.88. He is over projecting. You don't have to measure it really, but if you have to, that's a simple way of measuring it. And this is an exam question if you get asked about these things. If you're really clever and have all these angles that you know them, it's good, but you don't use them in real life. Dr. Farkas from Canada spent hours and days and weeks measuring everything on thousands of patients, and they have all these angles. There's a nasofrontal angle, 115, 135. I'm just showing you, just to have an idea. There's nasofacial angles, 30 to 40 degrees. They all measure the relationship between the tip, projection, and the rest of the face. And again, nasomental angle, which is about 120 to 130, as you can see it like this. Then there's the mental cervical angle, again, nose, chin, and the rest of the jaw here. So all these angles, there's so many of them, but they're not really used in clinical practice. The little things that you want to think about in clinical practice as well is the chin, because chin, the relationship to the nose is very important. A lot of patients with very small chin, they would look as if they have an over-projected nose. So sometimes we put chin implants in some patients. And the simple way of measuring, obviously with major variations, a lot of variations here, that the upper lip should be slightly forward compared to the lower lip, about 2 millimeters. If you pass a line through them, it should go through the chin. It's true for most women, but not men. So it's something that you can actually use every now and then if you want to be quick measuring these things like this, but there are lots of other measurements as well. So if that line goes across is good, but if it goes in front of it, so that small chin, if the chin goes through it, it's a big chin. So here's a patient with, you can see, she's got a small chin, she had a hump and all that, and the line is not going through it. After chin implant and rhinoplasty, the line is going through it. Things look better. The dorsum is interesting. Obviously, the dorsum is a very important part of the nose. It's quite often difficult to correct, and you have to be aware of the difference between male and male, for example, male and female, for example. There's a description of this brow tip line or lateral aesthetic line that people talk about in literature, which is nice. It's like a shadow that I want to create, especially in female noses like this. You want to create that shadow. If your nose has a hump or is deviated, you don't see that nice line when you take a photograph with a reflection of light. So if you can create that line, it's nice. So here's that lady, she has it here. And this is the patient I showed earlier. She's a SYLVIA who was unhappy. After she had it done, you could see it already. You could see that reflection because the nose is straighter now and there's no hump. The height, never give a man a low dorsum. It will look like, it'll be feminine immediately, and that's wrong. So the man's dorsum should be a bit high, or straight. Women are acceptable to be a bit low, but not too low. I think she's slightly too low. Also could be straight, but they nicely have a supratip break here. That's the feminine nose. Because in reality, the projection of the tip in females, in women, is slightly more than men in comparison to the rest of the nose. So the only measurement that is more in women than men is the projection of the tip. So the tip itself, the tip is complex. You have to look at a lot of things. You have to look at the shape of the lower laterals. You have to palpate them, feel them, what the size, there's any space between them, all the reflection of lights and all that. So I palpate them and I look carefully and I can actually tell the shape from looking at them, and you can see the shadows and everything. Here's so many variations. Here's a boxy tip. It's got huge bifidity, space between the lower laterals. Bulbous tip because it's very large convex cartilages. It's amorphous, means you can't see what's happening. She's got very thick skin, that's why I can't tell. The other thing is the nasolabial angle, because the nasolabial angle is very important again for femininity or masculinity. Nasolabial angle should be about 90 in men. In women, could be a bit more open than this, like lifting up again. So that's important as well. And columella show, interestingly, all the papers say 3 to 5 millimeter, and I really think 5 is too much. Nowadays, 5 is really big. I think maximum should be 3 millimeter, but we're still showing that. Here is the male and female differences. Nasofrontal is a bit more obtuse here, and again, the nasolabial in women is more obtuse than men. Alar base. So the alar base is important because a lot of patients nowadays again come to me, doctor, this is too wide. Realistically, that width here should be, or the dorsum here should be 80% of the width, but the easiest way is it should be equal to the intercanthal distance. If slightly bigger, yes, okay. It's too much bigger than that, it's probably big. But you can measure that in the clinic easily and show the patient as well, because a lot of them say, I want these to be reduced. You can look at this basal view. This is the infratip lobule here, should be 1/3, and the rest is 2/3 when you cut it anterior to the vestibule here. If you cross a line across the columella where the medial corona here converge, this is half and half. This is like the ideal measurement in a Caucasian nose, really, but not obviously in African nose and so on. So ethnicity makes a lot of variations. And most of these measures we still have up till now are Caucasians. Now, obviously, we're ENT surgeon. We really have to look at the nose properly. So we have to examine the septum, look at the septum, determine its internal valve and valve collapse as well. Valve collapse is very important. When you look at people breathing like this, she's breathing normally. I didn't say anything to her. She looks fine. So I don't tell my patients, oh, breathe for me, because you're breathing anyway. If you tell somebody, breathe for me, this is what they will do. They will collapse, yeah, because they just consciously start breathing, and you'll think, oh, they have valve collapse, it's overdiagnosed. So just see if there's any collapse when they're breathing. Usually it's after previous surgery with too much excision anyway. So don't consciously tell the patient to breathe, but look at valve collapse. Obviously, the valve is a cross-section area between the septum, upper lateral, and inferior turbinate, and is a very important part of anatomy that really affects the airway. Palpation really is important. I see a lot of residents, or registrars and so on, that don't actually palpate the nose, and I think it's essential. You want to feel the skin, how thick it is, how thin, and so on. any irregularity, especially with previous surgery. That tip recoil is just push it. It's because if there's no cartilage underneath, it's been removed from a septum, it just go in and come back slowly. I feel the alar cartilages with my fingers, and I actually push here the columella to see if the septum is there or not. Sometimes just feel like this, see if the spine is there. You could tell if cartilage is there, there's weakness and so on. It's very, very important to do it. And photography is essential. A few years ago, the paper published a questionnaire, and they found about 5% of surgeons in the UK do rhinoplasty without photography, which is it's not good practice, and medical legally is not defendable, basically. And that was about 10 years ago, that paper. So I don't know what it'd be nice to repeat that now. Essential to have photographs. Why? Because then you could discuss with the patient what we're going to do. In preoperative planning, you use them to plan what you want to do. And during the operation, you have to have them on and to look what I've done, what I'm doing, and refer. And I think really, really more importantly, assessment of your results. And you learn from your results so much from what you've done and related to the photographs. And as I said, medical legally, you have to have photographs for rhinoplasty. Photographs have been described very well. This is the plane you go through, which is the Frankfurt plane that comes from the upper tragus here to lower orbital margin, so the patient's head is not tilted. There's guidelines. I still show this picture. You can find it on the internet. I don't know if you can see that, but the guidelines for the photography of septal rhinoplasty. And these are the main ones you have, which is the frontals, lateral, and obliques, and the basal one. But you can have close-up ones like this, and superior ones like this, or two types of basal views, like a basal one and a basal radix, so you can see the whole of the nose from below. And you can have this helicopter or bird's eye, whatever, if you want to look at it from the top to see deviations, but it's just rarely done. Very soon, the NHS will stop doing septal rhinoplasties, so it's all going to be private. Probably, we'll see. It's pushing us, even us now. We'll see. We are resisting. But we'll keep teaching it. So now, finally, computer imaging. Is that good? There's a lot of actually data to show, but not every surgeon uses computer imaging and morphing of the pictures, because nowadays the patients demand it. The private patients, obviously, they want to show. A lot of the patients ask me, and I'll use it. I think it's useful. You show the patients, okay, we'll do the hump, but I think we'll do the chin as well. Or the patient wants too much, you keep doing changes. Oh, this patient is not right. You could tell sometimes the patient that we shouldn't have the operation, yeah? So I think it's useful in my personal experience. So for many years, I used this American program, which is reasonably expensive, but not too expensive. This one is about 10 times more expensive. So this one is fine. But nowadays, this is £5, an iPhone. It works the same. So things have advanced a lot. And this is now coming. This is me playing with the 3D. Obviously, that's really expensive. So I've changed my nose already. I'm going to change a bit more. You can play as much as you like here. Is that better? We don't know. So now I'm making myself up-rotated tip, which is not, obviously, is not very masculine. So this is what's coming now. They're trying to sell it to us. It's very expensive. Some surgeons are using it, but there's no data in literature to show if that 3D has more advantage than other ones. So we don't use it routinely. But there is some data shows the computer imaging, the 2D types thing, improves patient communication with the patient and expectations as well. So that's some data on that published years ago. But you should not really keep playing and keep doing too much, because if you can do as much as you like, but don't be detached from what you could really do. I actually make the nose, I think, a bit worse than I can make it. So I give that myself leeway to the patient. Oh, it's much better than the program. That's what you should do. Don't do too much. That's something you can't really do in real life. And that comes with experience as well. And don't tell the patients exactly what it's going to look like. So sometimes the patient won't take the pictures home, so I give them the thing. Image manipulation is a means of communication, does not imply a specific guaranteed outcome. It's very important to give them that. Now, when you're doing rhinoplasty, it's important to document. And on the day you see the patient, you see them for a long time. So you have time to assess and put your plan and everything. That's the best time that you actually will think about it. So you really have to write everything. I write good notes. If you want to use drawing sheets, I don't, but I write a surgical plan. My plan is 1, 2, 3, 4, 5, 6. The complications is informed consent. It's really nice to have it in the notes and in the letter that you dictate. But here are examples of sheets that people use, diagrams, every little deformity you can just tick here. I personally just prefer to write it. And this is the computerized one, the Gantt diagram, which you can just click the button and adds the change that you want to have. I have it, but I don't use it. So just to conclude, I think analysis is important. And again, examining the nose, inspection, palpation, photo review, and planning. That's it. Thank you very much.